Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with the director of the Yale Cancer Center, Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. This week, guest host Dr. Tracy Battaglia is joined for a conversation about breast cancer oncology with Dr. Maryam Lustberg. Dr. Lustberg is a professor of internal medicine and medical oncology at the Yale School of Medicine. Here's Dr. Battaglia.
Well, let's dive right in. I think we'd like to start our session by just learning a little bit about who you are, Dr. Lustberg. What brought you to the field of breast oncology?
Yes, happy to talk about this. So I've been a medical oncologist focused exclusively on breast cancer for the last 2 decades. I became interested in working with patients and families dealing with breast cancer early on in my medical training. I really enjoyed the close bonds that physicians and patients were developing as they tackled this scary diagnosis, and it was a population that I really enjoyed working with. And at the same time, I was also very much drawn to the active scientific inquiry as well as clinical trials that were being devoted to breast cancer, and thought that this was a good way for me to get involved both as a scientist and a physician to try to make an impact in this very common disease.
So I wonder if we could just start by, if you could break down for our listeners, what are the most common kind of breast cancers and the treatments that are available? I often hear oncologists say that there's not just one kind of cancers, there's hundreds kinds of cancers. Maybe you can break that down for us.
Yes, exactly. And similarly, we also like to say that breast cancer is not one type, but multiple different types, and each of them is very unique. I think a good way to start breaking down breast cancer is into the category of, is it hormonally driven or not hormonally driven? And hormonally driven breast cancers comprise approximately 2/3 of all our breast cancer types. And these are characterized by rich expression within the tumor of receptors for estrogen and progesterone, which are the main female hormones. So these hormonally driven breast cancers are most common, and we can certainly talk in subsequent questions about. We have a lot of great treatments for hormonally driven breast cancer. And then the second categorization is the breast cancer driven by what I call a growth antenna or growth signal called HER2/neu. And so being is the tumor HER2/neu positive or HER2 negative is the second big categorization. And so some tumors rely both on estrogen receptor pathways as well as HER2/neu pathways. And to make it a little bit extra confusing, in most recent years, the categorization of HER2/neu has gone through many changes, including now we have a category of HER2-low. So it's not clearly positive, as we have been used to categorizing it in distant years, but it has a little bit of that signal. And with advances in our systemic therapies, it's an important category to take into account for some patients as we describe their breast cancer.
Thank you for breaking that down for us. It feels a little bit overwhelming to sort of hear you explain it. And so I wonder if you can explain to our listeners, how do you know what kind of tumor you have?
So one of the important aspects to keep in mind is that breast cancer care is very much a multi-specialty type of practice. So all of us come together as a team in this multidisciplinary way to deliver the best, most personalized type of breast cancer care to our patients. So one of our key team members is actually the pathologist. So after a biopsy is taken or after a patient may undergo breast surgery, that tumor tissue is actually very carefully inspected for size, lymph node status, but additionally, the tumor tissue is also looked at for different drivers of it. And so there's very specific staining protocols and testing protocols where the pathologist is actually looking to see what are some of the categories that I previously mentioned. Is there evidence that there's hormone receptor expression? Is there evidence of HER2 expression? So I think a correct tissue diagnosis is so central to what we do. So that's one of the first steps for us to be able to devise the most accurate and personalized treatment plan for you.
That's really helpful. So the multidisciplinary team will look at your tumor and tell you which type of tumor that you have, and that will in turn determine the types of treatment you have available to you.
Exactly. And typically it starts with a biopsy. I think that biopsy gives us that initial clue in terms of, again, what type of breast cancer this is, depending on the type, as well as some of the imaging information. Breast radiology is also a key component of that multi-D team. So in addition to the biopsy, understanding based on imaging, and that could be mammogram, ultrasound, and in some cases breast MRI. What is the approximate extent of disease based on size and lymph node status? And all of these pieces of information are brought together. And typically there's a discussion in a multidisciplinary tumor board, or sometimes an informal discussion among all the different specialties to kind of decide what are the next steps in terms of that personalized care for the patient diagnosed.
I think it's really helpful for our listeners to understand what happens behind the scenes after a biopsy is taken. So thank you for breaking that down. I'm going to have you hold your thoughts about treatment because I want to sort of change our conversation to talk a little bit about early detection and specifically, it's hard to not listen to the news and hear a lot about the rising incidence of cancer in young people, and specifically breast cancer in young people. So can you tell us a little bit about what's behind this rising incidence of breast cancer in young women?
I think it's a really wonderful, important question, and we're still actively learning exactly what is driving this rise in trend in diagnosis of breast cancer in younger women, those under age 50 or under age 45. I think what we know is that it's probably not one factor that's driving this increase, and it's multiple factors, including our lifestyle factors have changed quite a bit in the last several decades with more sedentary culture, kind of as we've become more technology dependent. We know that there's been changes in dietary patterns, including increased processed food consumption, increased fat intake. We also know that there have been changes in reproductive patterns with some delayed childbearing that we have noted in the last several decades, as well as delayed breastfeeding. Now, all of these factors are not in any way blaming the patients for developing breast cancer. That is not what I'm saying. In many patients, we actually don't have a clear cause of why they develop breast cancer. They could have done all the right things and been the healthiest that they could have been. So I think there's a lot of unknown factors in terms of why any individual develops breast cancer, and that also goes for younger women with breast cancer. But I think there are theories that in many ways, kind of our exposure to hormones have changed, our exposure to kind of environmental factors may have changed in recent years. We're still trying to understand exactly what's driving this increase in rates.
Yeah, it sounds really complex. And there certainly are things in our history that we can't really change, right? Like
Exactly.
Our family history, for example. But then there are things that are potentially modifiable.
Correct.
like our lifestyle choices. Maybe you can talk a little bit about the difference between the things that you can change and the things you can't.
Absolutely. So as you mentioned, our family history, having a primary direct relative with breast cancer is one of the central risk factors for breast cancer, or having a genetic predisposition, a set of genes that can increase the probability, the lifetime probability of developing breast cancer. Obviously, we can't change our family history. We can't change our genetic makeup for certain patients who've had other types of exposures for other cancers, such as radiation treatment for other cancers. Those are things we can't change. But in terms of modifiable risk factors, these are our health habits. And that includes things like exercise. It includes our body mass index and whether we're falling in that overweight or obese category. It relates to alcohol use. We have more and more data about stronger associations with moderate to heavy alcohol use being associated with a higher chance of developing breast cancer. So these are factors that we have some control over, and these are things that can absolutely lower the lifetime risk of breast cancer.
So healthy lifestyle, behavior, everything we've been taught since we were younger
Yes.
also will reduce our breast cancer risk. Is that right?
Yes, and what's interesting is that cardiovascular disease, which is actually the most common cause of death in the U.S. in both men and women, cardiovascular disease factors actually have shared risk factors with breast cancer. So kind of you get a 2-for-1 as you kind of address your breast cancer risk factors. You're also addressing heart disease risk factors. So kind of maintaining that healthy weight, being physically active, at least 150 minutes a week, if not more, and then limiting alcohol, focusing on kind of more of a plant-forward diet with more plants, less animal fat, less processed foods and sugars. All these are all things that can help both your heart as well as your breast health.
That's great. Thank you for that advice, Dr. Lustberg. In the last minute we have before we break, I want to ask you you talked about lifestyle and behavior. What about screening and early detection for our listeners?
Yeah, so it's really important to know your risk of breast cancer. There's going to be a national movement to really focus on each individual woman really understanding her risk factors for breast cancer. And for women at average risk for developing breast cancer, typically we do recommend screening starting at age 40. But depending on if you have other risk factors, screening should really be individualized to your risk. But starting with an average risk woman, then mammography starting at age 40, and then depending on what your breast tissue looks like on a mammogram, how much glandular tissue there is relative to fatty tissue, that actually determines a factor called your breast density. And knowing your breast density is now the law. It should be in your mammogram report. And if you scroll down, you should be able to see what type of density you have. 50% of women in the U.S. actually fall in that higher breast density category. And what that means is that it may be more difficult for a radiologist to see solely relying on the mammogram the extent of how your breast tissue is. So typically a supplemental imaging, whether it be an ultrasound or in some cases an MRI, is needed to be able to see more clearly. In addition, breast density is actually an independent risk factor for developing breast cancer. That higher glandular tissue is more susceptible to changes that may predispose it to cancer. So knowing your breast density is another important facet of knowing your risk.
So many aspects of your background influence your own personal breast cancer risk.
Correct.
Well, we have covered a lot of ground in this first half, but we're going to break now to take a 1-minute break. We're going to come back and we're going to pick up on all of the details you gave us about tumor and different types of cancers and personal risk to talk about personalized and precision medicine and treatment. So stay tuned to learn more about improving your outcomes for breast cancer care with my guest, Dr. Maryam Lustberg. We'll be right back.
Support for Yale Cancer Answers comes from Smilo Cancer Hospital, where all patients have access to cutting-edge clinical trials at several convenient locations throughout the region. To learn more, visit smilocancerhospital.org. It's estimated that over 240,000 men in the U.S. will be diagnosed with prostate cancer this year, with over 3,000 new cases being identified here in Connecticut. 1 in 8 American men will develop prostate cancer in the course of his lifetime. Major advances in the detection and treatment of prostate cancer have dramatically decreased the number of men who die from the disease. Screening can be performed quickly and easily in a physician's office using 2 simple tests, a physical exam and a blood test. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilo Cancer Hospital, where doctors are also using the Artemis machine, which enables targeted biopsies to be performed. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Well, welcome back to Yale Cancer Answers. This is Dr. Tracy Battaglia. I am joined tonight with my colleague and guest, Dr. Maryam Lustberg. We're discussing breast cancer diagnosis, and we've had a riveting conversation for the first half of our time, really breaking down the types of different breast cancers, types of risk factors that go into developing breast cancer, and even things you can do to prevent or find cancer early. But we're going to transition our conversation now to treatment. We heard a lot about the different types of tumors that dictate the types of treatment that you get. So I'm going to ask our guest, Dr. Lustberg, to talk with us about the different types of treatment that are available to breast cancer and how they relate to the type of tumor that you have.
Thanks, Tracy, for that question. So multiple factors going into us advising our patients in terms of the type of multi-D treatment that they might need. So we've talked about the subtypes of breast cancer. That's an important factor. Additional factors include the stage of the breast cancer. So we have 4 stages. And for kind of the earliest stage breast cancers, generally we focus on starting with local regional treatment, which generally consists of surgery first, and really truly understanding as a consequence of surgery exactly how much tumor and disease involvement there was. And then after that, kind of depending on the type of surgery that was had, the amount of disease, and the type of breast cancer, deciding on whether radiation is needed, which is another local regional treatment, and then additional therapy in the form of systemic therapies. These are therapies that treat the whole body and may consist of the category of endocrine therapy, also known as hormonal therapy or anti-estrogen therapy. They may consist of chemotherapy. They may consist of HER2 monoclonal antibodies or HER2 treatment, immunotherapy in certain cases. So these are all different categories of systemic therapy that may be given in sequence or combined with each other depending on the situation. There are situations such as in stage 4 breast cancer where focusing on the best and the most targeted systemic therapy is the best place to start, and not taking time for local regional treatment because that takes away from time to really treat the whole disease process in the body. So all of these factors come together for us to kind of decide what are the right combination of treatments. And all of this is often discussed kind of, as I mentioned before, as part of that multi-D discussion with all the specialties involved.
You started out describing the importance of the multidisciplinary approach to cancer. And as you describe the treatments, it becomes more apparent how important that is. I wonder if you could talk about, there's so many choices for cancer treatment, both the modality and the order, as you point out. Like, we used to always start with surgery, for example, and now we're sort of rethinking the order. So there's the types of therapy and the order of therapy. And how does that decision-making process happen for a patient? Can you walk us through that?
Yes. So it goes without saying that the patient has a key central role here in terms of many of these decision makings, if not all of it. I mean, really, this is her body, and she gets to decide what is done. We are guides to kind of share the evidence of what we know so far about different biological characteristics of the tumor and what are the pros and cons of each approach. To give you a more tangible example, for example, the order of therapy for our non-hormonally driven, non-HER2 driven tumors, which are known also as our triple negative tumors, actually in stage 2 and stage 3 breast cancer, giving upfront chemotherapy plus immunotherapy has so many advantages, including having a real-time response measure of, is the combination actually working for the biology of this breast cancer? So by giving that upfront treatment and not rushing to surgery, we're truly interrogating the biology of the breast cancer and making sure that we're on the right track. And then when the patient does ultimately go to surgery, then we have an additional measure of how good were we in terms of targeting this tumor? Was there any tumor left? Was it a partial response or no response? And that can determine then additional systemic therapies that are given subsequently. So I would say kind of it's all those factors again. Patient plays that central role, and then in addition, feeding that shared decision-making model is kind of the scientific evidence of the biology of the cancer, what can be realistically surgically achieved, like is a tumor small enough for it to, for example, undergo surgery first. But patient preference on the type of surgery she wants is also a key factor. So there's a lot of discussion, and I would like to say that there's no reason to make a rush decision on many of these factors. Typically, it can take several weeks, if not longer, for us to kind of bring all these pieces together and also kind of have multiple conversations with patients so that they're fully informed and are truly making a decision that's right for them.
I think that's such a critical piece of advice that you're giving there, which is really the urgency of decision-making. I mean, I think any of us who have had the experience of cancer or a loved one who've had cancer, there's such a sense of urgency to do something immediately because you want to get rid of this, toxin that's in your body. And yet I'm hearing you say that it takes time and thoughtfulness to put together the appropriate treatment plan that makes the most sense for women. So maybe you can just speak to that a little bit more.
Yes. First, I would like to acknowledge that the experience of going through this as a patient and a family member, that's something that I can't fully imagine. I do want to acknowledge that from meeting thousands of patients and families over the years, I do want to validate and acknowledge that it can feel very scary from having these conversations with them. And yeah, that sense of urgency that you're talking about is absolutely a real feeling. I don't want to dismiss it. But then the scientific counter to that is that we actually have really strong data that taking our time is okay. And it can actually help you find that right treatment plan. Many of these breast cancers have actually been in the body for quite some time. And so taking those next few weeks to really decide on the right treatment plan has not in any way been shown to be detrimental. It can also open up doors for more novel therapies, such as being screened for clinical trials, which we think are super important. So yes, I both hear and validate those feelings, and at the same time, I think I can assure my patients that it's okay to take our time.
That's great. I want to get back to the clinical trials question in a moment, but I want to focus a little more on the shared decision-making piece and what goes into making a decision. And there are so many things to consider, obviously, but side effects are one. And side effects that affect people differently based on their age. So one, I think, very prominent example of that is fertility issues and impact on fertility for younger women with breast cancer. So I wonder if you can take a few minutes to talk about that.
Yes, absolutely. So I think younger women, it's one of the central questions that we always ask when we see patients under the age of 45 is, no matter how many children they've had, fertility is a personal decision, and what completes your family or what that looks like to you is a very individual decision. And so kind of in those initial consultations, it's very important for your oncology team to be checking in with you about your fertility goals, what's important to you, whether you desire to have more children or any children. And so part of the decision making is and taking that time is that there, for those who do want to have more children in the future, depending on the type of treatment, I think taking the time to meet with a fertility specialist so that certain measures, including egg harvest or fertilization, are taken. I think that's important. The most toxic of our therapies to fertility is chemotherapy, and I would say that there may be some gray zones in terms of when chemotherapy is needed or not, and so that may or may not play a factor in that shared decision making that some younger women make. But then there are cases where the benefits of chemotherapy are very clearly evident. I think patients have some hard decisions to make because there are some competing factors and competing goals. But I think it doesn't have to be in opposition, is what I'm trying to say, is that we have wonderful fertility preservation techniques and technologies, and that we know that pregnancy after breast cancer is safe based on multiple retrospective studies, as well as the recently reported prospective positive study. So I think we can take the time to really work on both treating the breast cancer in the most comprehensive way, but also kind of looking at some of those long-term goals, such as fertility and family creation.
That's wonderful. I'm sure we can talk a whole segment about this topic of fertility and cancer treatments, but maybe a takeaway point for our listeners is ask the question, what is the impact of the different treatments on fertility? What are my options to address those side effects? So thank you for that. Before we close, I just want to give you the opportunity to talk again about the importance of having access to clinical trials and what that means in terms of treatment.
Absolutely. So it's a good reminder to all of us that every treatment that's currently known as the standard of care or current practice actually came from a prior clinical trial from years ago, from patients and researchers really working together in partnership to advance the science of breast cancer care. Asking the question in your visits, do I have any clinical trial options available to me, will be a further prompt to your clinical oncology team to make sure that we're not missing any potential opportunities for you.
Dr. Maryam Lustberg is a professor of internal medicine and medical oncology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.